Good morning, good evening, good afternoon, everyone. Welcome, everyone, for this fifth webinar of WSPOS Worldwide Webinar. Today's webinar is on superior oblique palsy, what, where, when, and why. We have eminent faculty and panelists for this. Thank you all for tuning in around the world. This is the fifth time we are doing. All of us are different parts of the country, and we are connected together from our own place. So it's great that we all could join in this difficult time. Before starting, I will make some announcement. Number one is all of you can open the browser on your mobile phone or wherever, www.menti.com, because we will be posting some questions here so that we can get answers from the delegates so that we can see how the trend is. And the passcode for today is 142317, and this is the menti.com. And if some of you want the QR code, this is what it is. I'm not posting the question right now. We can see the first question. I will tell you when to answer as we go forward, because there is a lag between this presentation and when you get between 30 to 40 seconds. So I will give the time whenever the questions are coming. So as and when you see, keep on refreshing it, you will see other questions. So this is, I request everyone to open this, and the code for today is 142317. We are on 3 platforms: Blueberry, Facebook, and YouTube. Type in your questions if you have any on the comment sections. Panelists will try to answer today during the webinar as many as possible, but some of the unanswered questions will be replied later. We will compile it and email to every one of you. You will get the opinion of all the faculty as well as panelists. Now it's my pleasure to introduce our today's panelist. The first discussant is Asmina Matafsi. She is an associate professor of pediatric ophthalmology and strabismus from Greece. She is at the Aristotle University in Thessaloniki. She is trained in both in Switzerland as well as the United Kingdom. She did her fellowship in Great Ormond Street Hospital in London under the guidance of Ken Nister. We have Shelley Klein from United States of America. She is the clinical instructor in the pediatric ophthalmology at Tufts University School of Medicine. She is also a president of American Association of Certified Orthoptists. She is the program director of Boston's Orthoptic Fellowship Program. It's great to have you, Shelley, today. Next, it's a pleasure to introduce my friend, Stacy Panelist. She is an associate professor of pediatric ophthalmology and neuro-ophthalmology at Stein Eye Institute, UCLA, Los Angeles. She is a native of Philadelphia, but she has enjoyed living in Los Angeles for the past 15 years. She is still continuing there. And when she is not practicing ophthalmology, she enjoys spending time with her family. You can see the 2 lovely daughters here in this picture. It's a pleasure to introduce my co-moderator for today, Dr. Mauro Goldsmith. He is the Executive Director of Strabos Institute, Sao Paulo, Brazil. He is also a professor of ophthalmology and chief of strabismus at SEMA Hospital. Now I hand it over to Mauro to introduce the other speakers. Before I do so, again, I will show this www.menti.com. You will see questions there, and we will see one of the questions, try to answer it. And the passcode is 142317. As Mauro is introducing the other speakers, we will advance the question. So keep looking at there as well. Mauro, all yours. And this is the QR code.
Thank you. It is a pleasure for me to co-moderate this session of this webinar with Ramesh. And I want to introduce Dr. Susana Gamio, who is the chief of the ophthalmology unit at the Children's Hospital of Buenos Aires in Argentina. She was the past president of the Argentinian Pediatric Ophthalmology Society and the Argentine Strabismus Center. Our other moderator, you all know from previous webinars, Dr. Ramesh Kikunyai. He is the head at Child Side Institute and Justi Ramananam Children's Eye Care Center, LV Prasad Eye Institute in Hyderabad, and he did his fellowship at Stein Eye Institute at UCLA. Dr. Hannah Leiba is a professor at the Hebrew University, Jerusalem in Israel. She's the head of the Department of Ophthalmology in Kaplan Medical Center in Rehovot, and she did fellowships in pediatric ophthalmology and in neuro-ophthalmology in Basco Palmer in Miami with John Flynn, Joe Gazer, and Norman Schatz. Dr. Steve Archer, the Ida Lucy Yacobusi Professor at the University of Michigan. He did a neurobiology fellowship at the University of Colorado, his residency in ophthalmology at the University of Chicago, and the pediatric ophthalmology fellowship at Indiana University with Gene Helverson and Dario Ellis. And the last but not least, Dr. Glenn Gould, Professor of Ophthalmology at the Queensland Children's Hospital in Brisbane, Australia. He did his fellowship at the University of Iowa with Bill Scott and Frank Judish. So for now, I want to ask Dr. Gould to start his presentation.
Thank you, Mauro. As Dr. Gould is changing over, you can see some more questions there on the screen. You can answer them. Glenn, you can unmute your slide. We can't hear you yet. You can go to the first slide. We didn't hear you. I think you need to yeah.
Right, thank you. I'm unmuted. Good evening. Sorry, moderators. Definition of a congenital fourth nerve palsy is a fourth nerve palsy present from early childhood. It's the commonest cause of fourth nerve palsy, 20 to 75% of cases, usually sporadic, and can decompensate in adulthood, especially with minor trauma or with loss of fusional amplitudes, and this may result in a sudden onset of diplopia. Patients are usually neurologically normal, though it has been reported in some patients with cerebral palsy. Torsional diplopia is rare and it's practically non-existent in congenital supraoblique palsies. When do you diagnose it? Facial asymmetry is one of the classical signs of congenital fourth nerve palsy, but it is not diagnostic of congenital fourth nerve palsy. It is also seen in acquired, long-term acquired fourth nerve palsies, and in some cases of polyheterotopy. Childhood photos will show a head tilt, and these are enormously useful, and they'll tell you the condition has been chronic. There are large vertical fusional amplitudes, up to 35 prism Doppler's or more, and a useful diagnostic sign is that hypertropy in upgaze is equal or greater to hypertropy in downgaze, and this is a characteristic of congenital fourth nerve palsies and not seen in other causes. The condition is rarely bilateral. Where is the problem? Unknown. Hypoplasia or aplasia of the fourth nerve nucleus, and abnormally long or floppy supraoblique tendon. Anomalous or absent insertions, and the question the panel may ask is, are floppy tendons simply secondary to denervation of muscle? Characteristic MRI findings seen in fourth nerve palsies, different patterns of atrophy. Radiology now becomes a little bit more complicated because some Koreans have reported in a series of 125 patients, 73% of them have an absent trochlear nerve, and supraoblique atrophy on the affected side, but 27% of the patients had normal trochlear nerve and normal supraoblique tendons. So I don't think the radiology has been completely resolved at this time, and its role is still up for grabs. Why do you operate? Symptomatic head posture, diplopia in the primary positions, and should you automatically tuck a floppy tendon if you find it? And the other question, going back to the radiology for the panel to discuss, I guess, is if the supraoblique is not atrophic on MRI, is this still congenital fourth nerve palsy? Thank you.
Thank you, Dr. Glenn. We will move on, and I want to invite Dr. Hannah to present her talk.
Yeah, Mauro, when Dr. Hannah is putting the slides, I think Shelley wanted to make a comment. She can make a comment on differentiating.
Thank you. I too had a slide, if that would be okay, or perhaps not.
Yeah, you can just say what you wanted to comment.
Okay, so it is important, even though I, like Dr. Cole, have found that most congenital superior oblique palsies are not bilateral. It is important to differentiate between a unilateral and bilateral superior oblique palsy. And generally speaking, depending upon the extent of the superior oblique palsy, the hyper is going to be greater typically in primary position with unilateral, as opposed to it being smaller in bilateral superior oblique palsy. Motility is going to show that there's no reversal of the hyper in the ipsilateral gaze, whereas with bilateral, you're definitely going to get a reversal of the hyper in lateral gazes. The head position to me is very telling, and I have a slide later on that I can demonstrate this, but with a unilateral superior oblique palsy, the head position is much greater. You're going to see that chin up head position, you're going to see the tilt and perhaps the turn. On bilateral, there's really not much of a head position, perhaps a small chin down. Torsion, again, is relatively small in unilateral and much greater in bilateral. If it's greater than, I would say, 7 degrees, to me, it's highly diagnostic. And the head tilt test is going to be positive with the head tilt to the affected side on unilateral, where it's going to be positive on both sides when it's bilateral. And the last point I would make is that there's a very slight V pattern with unilateral superior oblique palsy, and it's a much greater V pattern with bilateral. So I'll save that other slide for later on. Thank you.
Okay, thank you. Dr. Leba, you can move on.
Okay. First of all, thank you for inviting me to this lovely project. Hello to everybody. My part was to talk about the neurological part of supraoblique paralysis, and actually I'm going to show you that everything is neurological or neuro-ophthalmological. So, okay. We're talking today about an isolated paralysis or palsy of the supraoblique muscle. And the supraoblique muscle is innervated by the fourth cranial nerve, so therefore we are actually discussing pathologies of the fourth cranial nerve or the trochlear nerve. The trochlear nerve, the nucleus arises in the midbrain, just ventral to the periaqueductal gray matter, and then it courses through the brain stem and goes out posteriorly, and it is the only coronal nerve that goes posteriorly. It goes through the just near to the posterior peduncle of the cerebellum, and then it goes the whole way anteriorly through the cavernous sinus and through the supraorbital fissure into the orbit. Okay, so what are the neurological part of it? We've talked about the congenital, and as Glenn also mentioned, it is in a part neurological as well. It may be related to trauma, it may be related to microvascular diseases, and very rarely it is related to tumors. The majority of isolated forced nerve palsies were presumed to be congenital, as has been said just a few minutes ago, even though they present throughout childhood and even in familial cases. Because as we saw just in the last presentation, that in congenital cranial nerve palsies, most of them have agenesis of or disinnervation actually syndrome, and there is absence of the trochlear nerve and secondary atrophy of the oblique muscles. And in the minority of them, there is no normal trochlear nerve and supraoblique muscle size, but there is an abnormal supraoblique tendon. And this may explain the variation of supraoblique tendon laxity that we see during these surgeries. And we've discussed already the differentiation between the congenital and the acquired cranial nerve palsy. I just reminded quickly. There are identified the congenital by a very high vertical fusional amplitude. The patients with congenital forced nerve palsy can often fuse up to 15 prism diopters compared to the normal range of 1 to 3 prism diopters. There is almost always overaction of the inferior oblique muscle. This is indicating a long-standing course, and the positive photo album test with pictures, all pictures showing this disease is very, very old. What about traumatic cranial nerve palsy? The nucleus, as we saw earlier, is located anteriorly and then goes posteriorly and goes out and decussates and then comes anteriorly. Its fiber courses dorsally and decussates in the dorsal, and then it goes anteriorly, as mentioned before. The trochlear nerve is sensitive to intracranial pressure variation, even very small variation. And we can have a traumatic forced cranial nerve palsy just from falling on our butt, sorry for that, because it is the finest and longest cranial nerve. It is the only cranial nerve to exit at the posterior part of the brainstem, and it has a very close relation to the edge of the temporal, and this is why in every small movement it can hit the forced cranial nerve. And the last one is a vascular forced cranial nerve palsy, actually vascular meaning either microvascular ischemia, stroke, CC fistula, and aneurysm. And we see more and more of them because of the better achievements through MRI and the better understanding of the MRI. And it's probably more frequent than reported in the past. In some of the papers, it goes up to 80% of the cases. People who are prone to have vascular forced cranial nerve palsy are just the same as those who the 6th and the 3rd, and they are older patients. Some of them have hypertension, diabetes mellitus, or dyslipidemia. Most of them are smoking and had a previous stroke or myocardial infarct. And I cannot finish my talk without at least mentioning skew deviation, because skew deviation is a vertical strabismus that may clinically mimic forced cranial nerve palsy and is caused by a supranuclear lesion. It may be the initial manifestation of a life-threatening disorder like brainstem stroke. In the contrary, the acquired isolated forcranial nerve palsy rarely presents a neurological emergency, and it happens through infranuclear lesions. So accurate clinical differentiation between the two is very important, but particularly in the acute part of it. I encourage you to go through the literature and read at least these two mentioned papers talking about the upright position test to differentiate between them. I do not go in detail due to the lack of time, and because since the first announcement of this test by Agnes Wong, it has a little or some opponents in the literature raising questions if this is the real way to do it. So I thank you for your attention, and I think I was on time, right?
Thank you, Hannah. I think you completed on time. We have some questions, time for questions. In the meantime, I will change 3 Menti questions on the menti.com. You all can see that questions when we initiate the discussion. I have a question. Mauro also will chip in with the questions. We can discuss some of the aspects of congenital versus neurological. They say that CT is the mnemonic, CNT, that is congenital and traumatic. In CT, we don't have to do a CT scan. I just want to know from from Glenn as well as from Hannah, what is the indication for imaging in congenital as well as neurological causes? Any specific indication for neuroimaging?
Can you hear me?
Yeah.
Okay. Well, the indication is actually only before you go to operate. If you're sure about the clinical manifestation of a congenital postcranial nerve palsy, there is no need to image, especially in young children. But if you are not sure what you're going to do in the operation, if you're going to recess or release the inferior oblique muscle, or you want to tuck or enforce the superior oblique muscle, this might be a reason to do an MRI. Otherwise, I don't see any reason to do an MRI in congenital in children, and also in adults. If they come, in the middle of the night, and you have to differentiate if it's really a stroke or something like that, or is it a congenital. If they can fuse like 10 or 15 prism diopters, it's a long-standing. It might be not congenital, but it's a long-standing. It's not urgent, and you follow. And if they have this position with asymmetry of the face, you can wait with the MRI until you have a very specific question.
Before going to the next question, Stacy, Shelley, can you comment on vertical fusion in congenital superior oblique palsy? What
Yes,
happens and what is? Thank you.
Yes. Actually, I was going to share if it's okay.
Yeah. Please quickly, you can do it. Yeah.
Yeah, I can do it quickly.
Yeah.
So on this particular slide, I just really wanted to demonstrate the pearls, I guess, in congenital right superior oblique palsy. Clearly, the history is going to be telling whether or not there's trauma involved, but you really, with a congenital superior oblique palsy, you are going to see these as I demonstrated here with these 2 children. This was a congenital right superior oblique palsy, and we have been following her for a number of years. She has that sort of classic chin down head position. It may not be as dramatic in this picture, but she definitely tilts her head. It is amazing. This child has a 25 diopter that becomes tropic, a right hypertropia and down gaze, yet in primary gaze, she can fuse it. She has amplitudes of, really close to 20 diopters of vertical fusional amplitudes. And we just follow her with her slight assumed head position and the long-standing nature. She continues to have 40 seconds of arc and fuses the Worth 4 dot. and we just continue to follow her. I'm suspicious that perhaps as she gets older and maybe becomes presbyopic or wants to go into a bifocal, then she might have some difficulties. But she's doing very well, and I just think it's a natural progression of superior oblique palsy to develop these large fusional amplitudes. On the other hand, this other child came in very acutely complaining of a diplopia, and you can see her head turn. Her head tilt is much greater. She had a negative neuro workup, so she's doing absolutely fine. And you can see down here that with prism glasses, it can straighten her head out. She had very poor fusional amplitudes, not more than, I would say, the measurement of her turn. Actually, was not even the measurement of her turn. It was very small. So I just think the long-standing nature is what is going to help you to develop those fusional amplitudes. It's not always a telltale sign, but very often it is. Thank you.
Thank you so much. Mauro, go ahead, please.
Yes, there are some questions coming from the delegates, and one, Dr. Hanna presented that superior oblique palsy might be part of a CCDD. I want to have other panelists' opinion, and also if we can consider superior oblique traumatic palsy during birth. Those are the two questions that are arriving.
Do you want me to answer?
Yeah, so you can tell us about the birth, superior oblique palsy, but I want to know from the others if they consider superior oblique, congenital superior oblique as a CCDD.
I might speak.
Go ahead, Glenn.
I might speak to the question of whether it's CCTD. If you look at the Korean papers, they would certainly suggest that the 73% or so of congenital force that they found with an absent trochlear nerve and absent with trochlear hypoplasia puts it into the category of a CCTD. The other ones, of course, don't fit, and they have not looked at polyheterotropy in those patients, so there may be another explanation for their patients. So I think some cases certainly do fit.
Yeah. Let me reframe one more question. You have proven that this superior oblique palsy is either congenital or traumatic. And you have non-congenital, non-traumatic superior oblique palsy coming to you, either at young age or older age. Will you image that patient?
Yes. When there is doubt, there is no doubt.
So specifically, all of you on the panel will image this kind of patients? Or there is any other opinion? Stacy or Stephen or Asimena? Do you have
I would image them. There can be an argument for an older vasculopathic isolated fourth nerve palsy to be observed in certain situations, but especially if they're very reliable and imaging is difficult to obtain for some reason, I think it's okay to observe those patients, but in general, I image acquired fourth nerve palsies.
Okay.
I have another question.
Neurological signs, you probably find your yield is very low. In a patient who has only a fourth nerve palsy and no other neurological signs, I suspect imaging is going to be a very low yield. It may not be justified.
Yeah, it approaches zero. I very rarely image these patients. I suppose I might if I had an acquired one, but and maybe those get skimmed off by the neuro-ophthalmology service. But I rarely see a superior oblique patient where it's not clearly fairly long-standing. I don't really see any that come in. You know, I developed the double vision yesterday.
Okay, thank you. Meena, do you have any comments? If you have comment, just make one comment, and then we can move on to Susanna's talk. Do you have anything to say? Yeah, go ahead, please.
A small comment. Sometimes pediatricians image these patients before they arrive to me, just to make parents happy that there's nothing else going on that is serious. When it comes to me, I would, if I suspect it's a new thing, I would image. If it's an underage patient, I would probably refer for a full workup and see if there are no other palsies, then probably not image.
Yeah. The specific question has been asked in the Menti as well, so I request everybody to answer the 5th and 6th question on the menti.com. And I invite Susanna to give her talk on inferior oblique surgery. So we will move on.
I just want one comment, very brief one, to what the seminar just told us. This is so true and this is so bad because people come with MRI so quote normal, just for the parents to be relaxed that the MRI was done, and because they didn't ask for the right question and they didn't do the right sequence, people are relaxing, but the disease is there.
Ramesh, may I ask a final question on this topic, which is what is your approach on a child, let's say 2-3 years of age, that comes to you with a huge head tilt, and the only exam you can, on the motility, you can see an inferior oblique overaction and a positive head tilt to the other side. What is your approach? Do you operate in terms of alleviation this patient? Do you go for the inferior oblique? Do you tuck? What is your approach? Dr. Glenn?
When I am sure that the patient had a congenital superior oblique palsy, I perform surgery at any age, but I have to be sure that that's the problem.
Dr. Glenn, want to go?
I think once you get reliable measurements, I generally operate. Probably by the time they get to you, they're older than 1. 1 or 2 years of age. Once you've got a good measurement and work out how big the angle is, then you can work out. Generally that's an inferior oblique weakening procedure, but of course you do exaggerated force ductions on the table, and if you find a floppy tendon, you tuck the tendon. I think it's decided on the table really what you're going to do, and determined also by your preoperative measurements. How many muscles you might have to do. If it's more than 15 doctors, you won't pick that up with the inferior oblique surgery. They may have to do a tuck and inferior oblique surgery.
Yeah. Now we'll move on to the surgical talks. The first speaker is Susanna. Please share your screen.
First of all, I want to say thank you because the opportunity to participate in this webinar. Many of cases of superior oblique palsy are treated by weakening the inferior oblique muscle.
Can you share your PowerPoint, please?
Excuse me? Where? Oh, excuse me. Share screen. Can you see? Can you see the presentation now?
No.
Not yet.
No.
Go to the
Not
Zoom.
yet?
Yeah, go to the Zoom screen. There, share screen.
Yes.
Yeah.
Share screen. And then share. Okay.
Yeah. Just play the PowerPoint? Yeah.
Yes, okay.
Thank you.
Many of the cases of superior oblique palsy are treated by weakening the inferior oblique muscle. Is the inferior oblique muscle really so difficult to weaken? There are many surgical procedures to weaken a muscle that is incapable of elevating the eye above the midline without the help from the superior rectus muscle. This question was asked by Forrest Hill in his excellent editorial from Journal of WSPOS. What surgical procedure are we talking about? The first technique was described by Duane, and it was a transcutaneous stenotomy at its origin. Then an attempt was made by detaching it at the scleral insertion. Later, resection to different points began. In the 80s, anterior transposition appeared. Then, stature transposed it to the nasal side of the inferior rectus. For very extreme procedures, we have the orbital wall fixation and the nasal myectomy. In this figure, by up, we can see the muscle relationships and the reference distances. Here you can see that the maximum amount of inferior oblique recession is 12 millimeters. Most of congenital superior oblique palsy are treated by inferior oblique weakening. Before starting the surgery, we must perform forced action. Intraoperative traction testing of the superior oblique muscle is very important to identify a very lax tendon that should be tucked. This method was described by Guyton, and the relative laxity of the tendon must be compared with the normal fellow eye. Why we must perform an inferior oblique recession? Because most of congenital superior oblique palsy have inferior oblique overaction, unlike the acquired ones that have superior oblique underaction. How to perform the surgery? Here you can see the steps, the conjunctival opening at 8 millimeters from the limbus to take off the inferior oblique muscle with a small hack, to disinsert, to suture with a 6-0 reabsorbable suture, to disinsert from the sclera, and to suture at the temporal side of the inferior rectus muscle, and then the conjunctival closure. In cases such as some authors prefer to perform a myectomy with cauterization of the inferior oblique, which is considered self-adjusting. This can also yield great results. Although I must say that usually I don't perform transposition in the superior oblique cases, there are some exceptions, and this child is one of them. This child that I am showing here had a superior oblique agenesia and was treated with anterior and nasal transposition of the inferior oblique. The technique described by Stagger with an outstanding result that maintained alignment with a 5 years follow-up. A second exception is this young man who suffered trauma at the level of the trochlea of the right superior oblique, and there was a disinsertion of the trochlea. He also was treated with the nasal transposition. In a second procedure, I performed a FADEN in the right inferior rectus, in the left inferior rectus to treat the residual hypertropia in down gaze. Finally, I asked myself, is the inferior oblique a friendly muscle? My answer is yes, because most cases treated with different weakening techniques, the results are very good. Thank you.
Thank you, Susanna, for that brief talk about inferior oblique surgery. We can take one or two questions. I will start with one question. Till what amount of hypertropia you choose inferior oblique surgery, and your choice of inferior oblique surgery for superior oblique palsy? And there are two mentee questions also. You all can look at it. Susanna.
I perform the inferior oblique weakening procedures till 20 Prince diopter in primary position. If I have more than 20, I have to add another muscle to the indication.
Other panel, any other difference of opinion, or do you change your dosage as well as surgery?
Ramesh, I agree with Susanna that an overacting inferior oblique that you recess would correct maximum of around 20 diopters in primary position, but it depends on the amount of overaction. If you don't have too much overaction and you have different measurements of hypertropia and different positions of gaze, I might decide for different muscles.
Okay.
Yes, I think it's very important the pattern of incomitance to choose the right muscle to weaken.
One more question on the audience. You have 18 prism diopters of hypertropia, and you have decided on inferior oblique surgery, but after traction test, you feel that superior oblique is very lax. Will you change your procedure, or will you continue with inferior oblique surgery?
You have 18 Prince diopter in primary position. Yeah. I think it's a very large amount of deviation for tackling the superior oblique only.
Okay. Any other opinion from Dr.
I am more traditional, more conservative. I usually start with the inferior oblique, no matter what the deviation is in primary position. And if it was not enough, then I'll add something, either the superior oblique tacking or the inferior rectus in the other eye. And I have to admit that in most of the cases, it's enough. You don't have to add anything else.
Yeah. Stacy, do you have any opinion on that?
Yeah, I think it's usually enough, but my cutoff in my mind is around 15 for one muscle. 18 is kind of close, so I think depending on the situation, I might still do it. If the tendon's really lax, though, I might do the tuck instead of the inferior oblique.
Okay. Thank you. We will move on to the next talk, and we can have some more questions from the audience. We will discuss some more. I invite Dr. Archer to speak about superior oblique tuck as well as superior rectus recession. Thank you.
Okay. My screen should be up. All right, I have no financial disclosures, and you were asking for different opinions. I was kind of holding off because here's where you're going to get it. So the first is what, and that's superior oblique tuck. And this is 30 seconds, so I had to cut almost half of the actual video. No, a little longer than that. So you engage the anterior portion of the tendon, pull it temporally, engage the rest of the tendon more nasally where it's more cord-like, adjust the amount of tuck, place a mattress suture, double mattress suture, tie it, and then check to see that you have the right tension with a couple of tests here. So when do I do this? This is easily the most common procedure that I do for superior oblique palsy. And a lot of these patients will have a lot of lateral incompetence. That is to say that their deviation is much greater on the contralateral side to the superior oblique palsy. We're going to pretend all of these are left superior oblique palsies for this talk. And so when it's very laterally incompetent, you're talking about doing oblique surgery. And if the vertical part of the incompetence is worse in down gaze, then it really points to the superior oblique that needs to be worked on. The other big thing that will make me do a superior oblique tuck is in adult patients, if they tell me that their symptoms are worse in reading position when they try to read, then that really makes me go to a superior oblique tuck. Another situation is that, especially in children, the superior oblique tuck seems to be more effective at treating the abnormal head position. Now, a lot of people have been talking about tendon laxity, and that's tendon laxity has a very good PR firm, but it informs me how much I'm going to tuck, but I do not use it to decide whether or not I'm going to do a tuck. If the pattern fits a superior oblique tuck, I'll do it whether the tendon is lax or not. So why? I'll give you one case that's kind of an example of why I do superior oblique tucks. This is a college student who is having trouble reading, and she has, as you see, a smallish left hyperphoria from her left superior oblique palsy. In down and right gaze, in the field of action of the superior oblique, she has 30 prism diopters, so there's a huge difference here. And here's where her problem is. This probably wouldn't bother her. She doesn't use that gaze position much, perhaps. But in reading position, she has 20 prism diopters of intermittent left hypertropia. And this is actually a common pattern in superior oblique palsy, is that in reading position where you're at near and the eyes are converged, you often have a much larger deviation than you have in just down gaze at distance or in primary position. So she had absolutely no tendon laxity. In fact, if anything, the tendon seemed a little bit tight. I tucked that tendon 2 millimeters times 2. I use this notation because there's a little confusion as to whether it's the setting on the tucker or whether it's the total length of both arms. So I use this notation, 2 millimeters on the tucker times 2 for both arms. And this is what I got from her. So I corrected pretty much all of the deviation in this field of action of the superior oblique. I corrected all of her reading position issue, all without overcorrecting her in primary position, which is the key trick here. I did create a little bit of a Brown syndrome here, which will get better over the following few months. So this is a series of patients where I looked at the amount of correction obtained in primary position versus the amount of position that was corrected by a superior oblique tuck in the field of action of the superior oblique tuck. And all the ones in blue, you see most of the patients had a greater correction in the field of action of the superior oblique muscle. At this end of the scale, as much as 30 prism diopters more correction in the field of action of the superior oblique. Here is a series of patients who did not have any tendon laxity, and they had tiny tucks, anywhere from 1 to 3 millimeters times 2. And you see that this was good at correcting the primary deviation. The field of action of the superior oblique had larger deviations, as did down gaze, which is why I picked superior oblique tuck in these cases. And it got you more correction for those positions than it did in primary position. And it essentially, the median for the lateral incompetence was 0 afterwards. So very effective procedure, even when you don't have tendon laxity and you have to do a very small tuck. So there's one other situation that I want to talk about. So we've been talking about where the deviation is greater down here. But if you have a situation where there the deviation is actually down and to the ipsilateral side, then you have to worry about superior rectus restriction. It doesn't have to necessarily be greater. If it's just not as much less than this position over here, then that can be a hint that's what's going on. So if you confirm that there is superior rectus restriction with passive duction testing at the time of surgery, then recession of the ipsilateral superior rectus muscle has to be part of your surgical plan. And here's where the where comes in. This condition seems to be endemic in Northern California and parts of South America. In Michigan, I very rarely see it. So this condition certainly exists, but I don't see it very often, and I don't need to do superior rectus recession for superior oblique palsies very often. All right, thank you. And let me see if I can stop screen share.
Okay, thanks, Steve. And now I want to invite Stacy to give her presentation.
Okay, thank you. So I'll be talking about Harada-Ito, when, what, where, and why. Harada-Ito, all of you know, is used to treat excyclotorsion, and I use it typically when it's symptomatic and more than 5 degrees. We know that excyclotorsion can be difficult to treat, and the procedure of choice for me depends on what is happening with the torsion, including whether there's a vertical deviation, how much torsion there is, and whether there's a pattern. In my mind, for excyclotorsion in general, Harada-Ito is a gold standard. But it can be difficult. It changes the path of the muscle. It can cause issues with restriction and with the superior rectus, especially if the frenulum between the superior rectus and superior oblique is not addressed. If there's a large vertical deviation with the torsion, then the Harada-Ito is not enough, and I often either add or substitute an additional procedure. Other options for excyclotorsion include rectus offset, superior oblique tucking, inferior oblique surgery, and more. What is the Harada-Ito? Originally described by Harada and Ito as a split of the superior oblique tendon with a suture passed about 5 millimeters behind the insertion and then anchored to the sclera 5 millimeters anteriorly. The more popular version now is the Fels modification, in which the superior oblique tendon is split and then disinserted and advanced anteriorly to the lateral rectus border and then inserted perpendicular, as is shown in this figure here from Rosenbaum and Santiago's textbook. I like to modify the Harada-Ito if there's a small vertical deviation. If this eye was hypotropic, then I would move the Harada-Ito anteriorly to help elevate. And if the eye was hypertropic, then I might move the Harada-Ito tendon posteriorly to address that. The Harada-Ito can also be done on an adjustable suture. There are some downsides. It's difficult, especially if you don't do it a lot. It requires suturing far back with the near the lateral rectus, which can be dangerous, and it changes the overall orientation of the tendon. So I just wanted to show a video of a modified technique that Federico Velez and a fellow that we have from Chile, Federico Solanes, put together with me, called a modified anterior superior oblique tuck, which is an alternative to Harada-Ito. So here we have the superior oblique splitting the tendon just as you might for a Harada-Ito, but instead of suturing and disinserting, what's done instead is a tuck, just like Dr. Archer loves to do, but only on the anterior 1/3 as a treatment for torsion. So kind of a similar effect to a Harada-Ito, but a lot easier and with no scleral suturing. So here you're seeing us do a tuck on a patient who had symptomatic excyclotorsion of just the anterior 1/3 using 2 sutures. After this, typically forced suction testing is done, and it's easy to change the amount of tucking if needed because the whole procedure is very quick. Just to follow up on that, we've done this on about 5 patients who have followed up longer than 3 months, and find overall about a 1.5 degrees per millimeter of tucking after 3 months. The advantage of that procedure as opposed to Harada-Ito is that you don't have to redirect the superior oblique fibers or disinsert or suture on the sclera. It seems to be stable over time, but admittedly, we have not done a lot of patients with this technique yet. So in conclusion, there are a lot of procedures available for the treatment of excyclotorsion. The Harada-Ito and this other modified anterior superior oblique tuck are both good choices in the absence of a significant vertical deviation. Thank you. I'll stop my share.
Yeah. Thank you so much. Excuse me. Thank you so much, Stacy. I request all the audience to answer 7th and 8th question on the Mentimeter, menti.com. And then after the discussion, I will share all the slides, what you have answered. Any questions at this point of time to all the panelists? We will start with the first question, and then Mauro can initiate. How much is the correction by inferior oblique weakening? Maybe just one word answer. All the panelists can answer this question. Just how much correction it gives if you do just one muscle surgery, that is inferior oblique.
I'll just answer. I usually say, like, for 10 millimeter recession, I get about 10 prism diopters. Just like a general rule of thumb. I don't think it's really possible to get much more than 14 or 15 with an inferior oblique recession, but it sounds like others do.
Yeah. Dr. Archer and Dr. Cole? Yeah.
I would say there's a limit to how much you can get, but how much you get is very much dependent upon what you start with. If you have 5 and you do an inferior oblique weakening procedure of your choice, I do myotomies, you get 5. You know, if you have 10, you get 10.
Dr. Goel, do you have any comment?
I think yes. Recession or myectomy is 15 if you do an anterior transposition. And I think the indication for that is if you have spread of comitants, you can get up to 25 in primary position. But you will always get an anti-elevation syndrome in the eye about which the patient must be informed before you operate on them.
This is why
Go ahead, Hannah.
Okay, sorry. I have to admit that again, you know, being practical is my golden way. And since I moved to myectomies, which is easier, faster, and I don't really care how much I correct them, because if the patient is happy and I still measure like 5 prism diopters of hyper, I don't really care. Most of the patients we are treating with inferior oblique myectomy are those who are congenital and decompensated. All the other, we have to go to the weakened muscle. I mean to superior oblique. But if we approach the inferior oblique, it's usually because the patient has been decompensated. And my belief is that before he became decompensated, he lived all his life with this deviation and was happy and was thriving and was active. If you just bring him back to the point before the decompensation, he's happy. So I'm happy too.
I think we have to remember that those patients have a large vertical fusional amplitude. So I think that the result of the amount of correction with an inferior oblique recession, it will also depend on the amount of undirection of the superior oblique. So there is a correlation. If you have an important undirection of the superior oblique, you might not get more correction in primary position.
Yeah, the fusion amplitude is an interesting issue. I very frequently have adults who have long-standing, probably congenital superior oblique palsies, and they're almost fusing 20-25 prism diopters of vertical. It breaks down intermittently, which is why they're coming to me for repair. And you would think that if you just made that a little better, they're almost compensated for what they've got. If you made that a little better, they ought to be fine. But and that's true for some of them. But there's a subset where they were happily fusing 20 prism diopters before the surgery, and you leave them 5 prism diopters undercorrected, and they can't handle that. I don't know why, but they suddenly want it all corrected after you start correcting any of it.
Yeah. The next question is how much you get the correction of torticollis in children after the alignment surgery? All the 3 surgical talk speakers can answer this.
I'm not sure I understand the question.
Yeah. How much is the torticollis correction you get after alignment surgery for superior oblique palsy?
If you can obtain alignment in primary position, you can alleviate, you can improve the torticollis, because the abnormal head position is due to the vertical deviation. In most children with congenital superior oblique palsy, weakening the inferior oblique alone, it's enough to improve the torticollis.
Yeah, I would say it improves it, but not as well as a tuck. I had a lot of patients where I was doing inferior oblique weakening and a lot of residual torticollis in those kids, which is not as common when they're treated primarily with a tuck. I don't know why that is. I agree. It's not the torsion. It's the vertical deviation. But a lot of these kids have little vertical deviations that are residual. I had one girl who had just a couple of prism diopters that you could bring out by prolonged alternate cover testing, but still maintained a large head tilt, and the head tilt went away when I went back and corrected those 2 or 3 prism diopters of residual hyperphoria. The other problem, though, is that there's a lot of these children have secondary musculoskeletal changes from long-standing head tilts, and they will often have some residual head tilt even when you have their deviation fully corrected, and that's more of an orthopedic physical therapy problem to deal with that.
Yeah. One more specific question. A patient has 25 prisms of hypertropia. Superior oblique is not lax. Inferior oblique recession has been done. There is undercorrection. What's the next muscle you will handle?
Depends on what the pattern. Oh, sorry. Go ahead.
I was just going to say it depends on where the deviation is larger. If it's larger in the contralateral gaze, then I would definitely love to do the inferior rectus. But it depends if up gaze, down gaze, side gaze, those details are really important.
Yeah, I would agree. It all depends on what the residual deviation is and what the pattern of incompetence is.
I agree. The pattern of incompetence is very important, but most of the cases need the inferior rectus recession.
There's another question coming here from the delegates, and also I'm interested in hearing all of you. Let's say a patient with bilateral superior oblique palsy with almost no or very small deviation in primary position, and all down gaze on the right and left, you have hypertropia, and patient is complaining of excyclotorsion in down gaze. What is your approach? Would you go for the tuck, or is there any other possibilities, such as recessing the inferior rectus bilaterally?
I like recessing both inferior rectus muscles for excyclotorsion and down gaze, especially if there's a small vertical, because you can address that with an adjustable suture. So that would be what I would do.
I agree. I prefer to recess both inferior rectus muscles.
Well, it kind of depends. If there's a lot of hypertrophy in side gazes, I'll do bilateral superior oblique tucks. If there's not much vertical deviation, alternating hyper and side gazes, then Harada-Ito, bilateral Harada-Ito works well. For me, recessing both inferior rectus muscles is kind of a secondary procedure if we don't get enough from doing the bilateral Harada-Itos, and that doesn't happen very often. But the occasional case where that will happen is usually a neurosurgical problem where the superior oblique muscles are completely dead from having had the nerves resected.
Tracy, do you do nasal shift when you do bilateral inferior rectus recession?
I don't usually, but I know some people do. Maybe if I'm doing a very large one, but in general, no.
Okay.
Could I ask how much nasally do you take it? Do you titrate that, or you just have a standard amount?
No, I just do like a half 10-to-1. I don't know. Someone else might have a better answer for that. I always just do a half 10-to-1.
Well, trying to correct torsion with shifting rectus muscles is really problematic for superior oblique palsy, because the other piece of this is there's usually a V pattern, and so any shift that you do to try to correct the extorsion makes the V pattern worse. So it's a trade-off there. As far as the nasal shift, if you want to maintain a neutral position of the muscle, I typically will try to recess when I do large recessions of inferior rectus muscles. Or superior rectus muscles for that matter. I try to keep the muscle along its normal path from the insertion to the apex of the orbit, which progresses nasally. So at about an 8 millimeter recession, a 5 millimeter nasal shift keeps it in line with its normal path.
There is a specific question for Dr. Archer. How much the superior oblique tuck can correct in the primary position?
Again, it's pretty similar to the inferior oblique. I've got patients with 10 or 15 prism diopters that I've easily corrected with a superior oblique tuck. Well, I'll just leave it at that.
I have to agree with Steve. Even though I'm not a happy tucker, if there is no overaction of the inferior oblique, and usually in the bilateral cases after traumatic palsy, usually they benefit very much from a bilateral tucking of the superior oblique, and I have to admit that I don't even measure. I just tuck it, but I'd like it to be the same amount of tucking in both eyes, and they're happy, and the head is straightened, and only in very few cases you have to come back and do the straight muscles.
Another question for the group is there a place for inferior oblique anterior transposition on superior oblique palsy? Because this is a restrictive surgery, and I've been seeing presentations of this technique as a possible option for superior oblique palsy. What is your opinion?
As I have said, I don't like transposition in this kind of patients. Some exception is the trauma of the trochlea, and the other one, the agenesia of the superior oblique tendon. No transposition in other cases.
Yeah, I don't like unilateral anteriorizations. They usually end badly. I do them bilaterally in patients with congenital esotropia and inferior oblique overaction with DVD. But unilateral is asking for trouble. Although there are people who publish on this with some regularity. The other thing is that may be a little more subtle. But it does cause a change in the appearance of the lower lid. You get some fullness of the lower lid with anteriorization. And again, that's a little more noticeable when you do that unilaterally.
There is a specific question for Shelley. Any role of prisms in superior oblique palsy, either unilateral or bilateral? Role of prisms?
I'm sorry, I didn't. Oh, the role of prisms. Thank you. I understand now. Yeah, thank you for that question. The measurements, you know, just even backtracking a little bit, so much surgical decision is based upon the measurements. And so it is really important, I think, that when we do the measurements, to do them in all the tertiary positions, and to, especially with the palsy, to extend out, I would say 25 to 30 degrees from fixation, and get a good measurement so that you can uncover a bilateral if it is there, and just to give the best knowledge preoperatively as to what muscles to attack. And then also evaluating torsion, which can be done in two ways, either with a double Maddox rod or a synoptophore, and to also share that information before making your final surgical decision. So measurements are really critical in terms of the surgical plan. When I'm considering incorporating prisms into a pair of glasses, my thought in this is I want to get the largest single binocular field as possible for my patients, so that on turns that perhaps may measure, 10 diopters or less, sometimes even more than that, if they have some good fusional amplitudes and have very strong fusion. What I typically do is, when I'm trying to decide whether or not this patient, if they do not have too much torsion involved, if in fact I can incorporate prisms. And what I'll do then is, obviously based on my measurement, I'll see how much, the least amount of prism that is required in the contralateral gaze to click those two images in together without overcorrecting on the ipsilateral side, and hopefully giving them enough vertical prism to help them in down gaze. My rule of thumb is to kind of expand their visual field. I would say maybe 10 to 15 degrees laterally, because I think in life that's about all we use before we turn our head to look at something. So I do feel that incorporating prisms do have an important role. I typically do not prescribe more than a total of 12 diopters of vertical prism into a pair of glasses. And sometimes a little bit of horizontal prism can be added. So, if a patient doesn't wear any glasses and, they're big on sports, that's not going to be a candidate for prism glasses. But there's certainly some population that do well with the prism glasses, prefer not to have surgery, and are very grateful for that option. Thank you.
I would like to ask you, when you see a patient that has a traumatic unilateral superior oblique palsy, how do you follow this patient, and when do you indicate surgery? I mean, he comes for a consultation, let's say 15 days after the trauma. How do you follow? How many exams, and when do you indicate surgery?
I'll just quickly jump in there. When we have a patient who's had a traumatic fourth nerve palsy, we obviously want to wait till we see if there's some recovery before jumping into surgery. And I personally will try to at least make them more comfortable until stabilization takes place with some temporary prism. I would say in the beginning, we see the patients every couple of months, but often do not think about surgery till at least a good 6 months or more from the time of the trauma, especially depending upon how intense that trauma is. And we'll just monitor it to see, as I said, if there is some recovery on its own.
Do you all agree with the 6 months waiting until you indicate surgery?
Yes, excuse me, I think it's necessary a stable deviation for deciding the surgery. You can see if the deviation is stable for 6 months, you can perform surgery.
Most of them recover.
I had one patient who recovered after almost 10 months. I in fact posted that patient for surgery at around 8.5 months. She did not get surgery done. She came at 11th month completely resolved. After that, I try to wait at least a year before I operate on these patients. So it's rare, but even that rarity I would like, because measurement wise it won't change much in superior oblique palsy, because we are not talking about like in 6-nerve palsy 40 prism diopters or 60 prisms. Here we are talking about very tiny deviation. So I would wait a little bit longer because of this experience.
Shelly, I wanted to ask you something about the prisms, because we've been taught the prism should be given in comitant deviation, and this is actually a non-comitant deviation. And how do the prism help them if the angle of deviation differs in eye movement?
I do understand your question. What I personally do is, and again, it's a certain group of patients that benefit from having incorporated prisms, but many are very, very happy. What I actually do is a vertical amplitude on the ipsilateral side. So if in fact my patient has a right superior oblique palsy, I'm going to turn their head, so that I'm going to do a vertical amplitude on the same side to see how much vertical prism they can handle without me overcorrecting them. And usually there is some amplitude there that I can deal with. I mean, if they're already measuring some of that hyper, since it's unilateral, on that ipsilateral side, then there's more leeway to do that. But many of them are very much thanked by having incorporated prisms and wear them for long periods of time, endlessly, sometimes year after year, when they come in for annual exams for refraction and just to check to see if the prisms need change, and are often very stable. So I have not found that to be a problem, as long as you evaluate that and have good measurements beforehand and make sure that you're not creating an opposite deviation on the same side as the palsy. And I can also, with a patient who is good to talk to, and I can explain to them what the difference is, sometimes they prefer it. I mean, anecdotally, I find patients are more bothered by double vision in left gaze than right gaze, and I think that has to do with driving and looking that way, whereas in right gaze, I think using the rearview mirror, I think they are a little bit better. So sometimes they don't mind being a little bit overcorrected and know that they need to turn their head rather than their eyes.
Yeah, the gaze depends on which country you are in. So in India, it's different. So this can vary.
Oh, yes, you're right. I'm sorry, I didn't think about that.
Yeah, there is one more question. Can I ask one question, specific question? Maybe Meena can answer this question. It's about evaluation. Congenital superior oblique palsy versus acquired. The family pictures are not available. Any clues to differentiate between acquired and congenital superior oblique palsy? Can you just throw on some light on this, please?
Other than the large fusion range, I think that's very important. What age are you talking about?
Audience has not told the age. Probably we can also look at the head tilt as well as facial asymmetry, I think, even if you don't have pictures. I think these things help in these kind of patients. Mauro, you had some comment? You're just...
Yeah, I want to say that probably superior oblique palsy is the type of strabismus where very small deviations make the differential diagnosis. And they are important, and that's why we have to measure in all positions of gaze. So if you have a right superior oblique palsy, and on the up right position, you have a left hyper, this indicates you have a bilateral superior oblique palsy, and you have to treat it as a bilateral superior oblique palsy. But my question is, how do you, what are the tips for you to say that you have a masked bilateral superior oblique palsy?
I think measuring in the up corner gaze, as you mentioned, is really important. Also, the amount of torsion. If you have a lot of torsion, like 15 degrees or more, and a small vertical, then you should be thinking about looking for that, and as well as a pattern.
You know, Stacy, for me, very large differences from the hypertropia from right to left and head tilt. You have to just keep in mind that you might be facing a masked bilateral superior oblique palsy, and I always I treat it as a unilateral case, but I tell the parents that it might happen to invert the deviation, and he might need a second operation if it happens after the surgery.
This is always true.
Yeah. I don't know that how it changes your management. I've got a large number of patients who are clearly bilateral superior oblique palsies, and they had such small deviations related to the less palsied muscle that I just treated them as unilateral, and they uniformly do just fine. The masked superior oblique palsy, I think, it certainly exists, but again, it's an over emphasized diagnosis. Most of the so-called masked superior oblique palsies, as Rick Saunders pointed out and Dave Guyton pointed out, are really just overcorrections. Just a simple overcorrection of a unilateral superior oblique palsy produces a pattern of incontinence that is essentially the same as a contralateral superior oblique palsy. So you have to be very careful to not confuse bilateral masked with just simple overcorrections.
Yeah. I'll just take 2-3 minutes to show the results, because around that, if there are any discussions, we can have. This is the first question. How many of us are fellowship trained? It's almost kind of 20% of the people are not amongst the viewers. The next question is, most of the people are from Asia, and then North America, and then Europe and South America. Do you get neuroimaging done in all non-traumatic acquired superior oblique palsies? Occasionally in selected cases, and we have no. Probably this question actually excludes congenital superior oblique palsy. So you can see there are some kind of mismatch in some of the things, like congenital and traumatic, most of the people won't get it, but in acquired, some of the people are getting, if the patient does not have any ischemic etiology. In congenital superior oblique palsy, my choice of surgery, most of them perform inferior oblique recession in terms of inferior oblique surgery. I can see a very, very tiny percentage of people, we discussed about it, doing a nasal transposition. So it's a rare group, but they do it. And there are some people doing inferior oblique myectomy as well. The next question, I do superior oblique tuck only when it is lax. Majority of them, always in superior oblique palsy, congenital superior oblique palsy. 2 people said yes. And this is a question for the panel. In acquired cases, how many times you do a superior oblique tuck and when? This can be answered after this results are shown. And few of them do it in all situations. It's very interesting to know. My choice of technique for Harada-Ito, classic is the majority. Stacy, you can see your technique in 13 people are still following. So I think there are some advantages and disadvantages of both classic as well as Phelps modification. And Stacy also showed a very elegant technique, and it's very simple to do it. In cases of superior oblique palsy with hypertropia more than 25 prism diopters, my choice of surgery, if you see, majority are in favor of inferior oblique weakening and superior oblique tuck. Minority of the people do still inferior oblique weakening only. I think there are other choice of surgery like contralateral inferior rectus or superior rectus, and also combination of inferior oblique and superior rectus. I think that can really lead to some kind of elevation deficit in some of the patients. We can discuss quickly about that. And this is the last question, and it's the most important. I think we have answered this. It's not only correcting the orthotropia in primary position. We need to look into down gaze as well as head tilt. And this is the criteria for success in superior oblique palsy. Probably is all of the above, but as surgeons, we may not be able to achieve all of it. That's one of the things we need to remember. Any comments from the panelists? It's the last few minutes, 3 minutes we have. Any quick comments? You can go ahead.
Well, one of the things we haven't talked about is where you have spread of cometants. And I guess that's where, for smaller angles where you have like up to about 25 prism diopters, where you have quite a marked spread of cometants, I think anterior transduction does have a role to play, but informed consent involves finding out what the patient does for a living. It's not for roof tilers, house painters, yacht riggers, or people who like to ride cycles, in which case you have to think of something else. But if with those angles up to about 25 or 30, if you add a superior rectus in as well, you do run the risk of overcorrection. And the worst result for superior oblique treatment is to overcorrect the patient because they have no vertical fusional amplitudes the other way, and they're very unhappy customers. So I didn't know how to answer the question of getting orthotropia. I always aim for a little undercorrection, and then people are kind of happy with that. But if they're unhappy, they're going to Michigan.
What do you do if that happens?
If they want overcorrection, I'll have to go and I'll operate on what you find. It may involve a rectus muscle recession or undoing what you've done. If it's overdone for an anterior transposition, you just convert it into a recession. But generally, you have to do something. They're very unhappy customers, and they don't go away, or they go to someone else. But generally, it does mean further surgery, or they get into another head posture or something like that. But it's a pretty rare complication. But I think if you're doing inferior obliques and superior recti together, which we have to do if you've got 35 or 40 prism diopters of vertical, then you run that risk, and you have to inform the patient. Then you might be into 3 muscles, of course, and doing the inferior rectus on the other side.
Any comments from? We are almost reaching the time. Quick comments from all the panelists. Maybe just one comment, and then we can close. Stacy, you can begin. Yeah.
Yeah, I thought it was a great panel. I would just say that I really like to do the inferior rectus on the contralateral side, and I don't think that got much attention today, as opposed to a superior oblique in many cases. So just that'll be my last plug. Thank you all.
Can I add to that? Does anyone do inferior rectus myopexy instead of recession in that respect?
Yeah, I don't like the inferior rectus. It's kind of a bad actor. It tends to have progressive overcorrection over time, more with Graves' patients, but also even with doing it for the superior oblique palsy. the place where the posterior fixation, the contralateral inferior rectus comes in, is we were talking about criteria for success, and that is one thing I would add in there is comfortable reading position is very important criteria for success, which wasn't mentioned in there. And so what you find very frequently is that patients who have inappropriately had inferior oblique weakening as their initial procedure will be perfect in primary position, their torsion is fixed, but they can't read. And for those patients, your only alternative is a posterior fixation on the contralateral inferior rectus muscle.
I think we need to close here because we are almost crossed our time. I just want to show this last one. Whoever has attended this webinar, they can avail their participation certificate. Please send an email to wspos@wspos.org. We will arrange the participation certificate. And I just want to remind you that we do have one more webinar tomorrow. It's about pediatric ophthalmology, strabismus, and teleophthalmology practice during COVID-19. I request all of you to log in, and you can see the upcoming webinars list on this slide. Please do join us and learn and share your knowledge. I just want to thank you, everyone from all over the world, for tuning in today. I see many of the people are from many countries. Thank you so much for joining. And I really want to thank our panelists, discussants, and my co-moderator, Mauro, for participating. Special thanks to Dr. Goel. It's almost midnight there in Australia. Thank you so much for participating so actively, and we had a productive discussion today. I just want to thank the entire team for providing this platform, and it was a superb live streaming today. And last but not the least, our WSPOS admin team is working very hard to make this happen week after week. I think it's a great opportunity for all of us to meet virtually and share and learn from each other. Thank you so much once again. Have a good evening and have a good day to all of you. Thank you.
Thank you. Thank you.
Thank you.
Bye.